Good afternoon or good morning, depending on where you are. This is Jeff Adest. I'm here today with Sandy Jensen to talk to you about FTCA. Just to start off with a couple of technical things, we will be sending out the slides in the presentation, so you don't need to send an email asking if you're going to get the slides. You will get them. You don't need to be taking pictures of the screen. Everything will come to you. Secondarily, we gave this presentation almost exactly in the same format previously on March 31st when the application was going to be due, earlier on. And now that they've extended it, we're giving it again because a lot of people were not able to attend the first time because of COVID or didn't have time to pay attention to it, and now want to pay it. We had a request to have it again, so we're giving it again. But if you listen to it in March, you don't really need to listen to it again today. There are a few additional slides which when we send out, you can see are in red. That'll show you things that are different, but I just don't want to get complaints that people are saying, why do I have to listen to this again or listen to it last time? So we're just letting you know that it's essentially the same presentation. Okay, so we are going to be talking about FTCA today, but before we get to FTCA, I want to talk to you about one other thing. We sent out a notice to hopefully all of you received it in the last couple of days. So all FQHCs have received, and now for the first time, lookalikes have received federal grant dollars relating to COVID. And hidden someplace in all the materials that you received is something which says that if you are going to be using that funding to pay salaries, which include hazard pay or any kind of premiums, you can only do that if you have policies and procedures in place that allow for you to use those funds under unexpected or extraordinary circumstances. So these policies have to be board approved as well. We have a sample policy for anyone who wants to reach out to us for a relatively minor cost. We have a sample policy, or you could do it yourself. But you need to make sure that you have that policy in place because you all are using, I don't want to say everyone, but I would say just about everyone is using those funds for salary related purposes. So make sure you have something in place to address it. Okay, so with regard to FTCA, so you've all done this many years in the past, right? Unless you're brand new, but almost everybody on the phone has done FTCA applications. And unfortunately, as the years go by, the applications become more and more complicated. So the things you need to do this year, are very different than what you needed to do last year. And over the past 5 years, they've made the applications much more complicated and extensive. They have also said in very clear terms that historically, as long as you submitted something, we're going to approve your application. That is no longer the case. As I mentioned on a previous webinar, we were at a FTCA site visit last year, and we had Christopher Gibbs, who's the person who's in charge of all of this, at the presentation. And he told us that last year they were holding up a number of applications, and that they was still in the end, we're probably going to approve them, but that starting this year, if the applications did not meet the requirements, they would not be approving people for FTCA. So I would say please make sure that you're doing what needs to be done in the application, and it's not just pro forma. The good news is that because of the extension, you still have a little bit over a month to get everything done. The bad news is there are a lot of things that need to get done in the next month, including have the board approve many different things that we'll go through today. So you need to make sure you get on this as soon as possible. And like I've mentioned in the past, if you need help with it, we'd be happy to help you with it. Any policies or procedures you need relating to it, we have models of and can provide you with. So again, the purpose of FTCA is so that you cannot get sued for malpractice purposes. And the reason, and again, this only applies to medical malpractice. It does not apply to slip and fall or anything like that. It applies to the organization and to all of your direct employees. For people who are 1099s, It only applies in certain circumstances. For example, if they're providing primary care, generally for specialists, it will not apply. And even in that case, it's only when they're direct 1099s rather than through a company. If they're through a company, they will not have insurance. Again, you will have insurance no matter what, as long as the service is within your scope and is within one of your sites. Right? We talked about in a previous webinar, because of COVID, they have now expanded, and now you could have FTCA coverage even for things you do off-site as they relate to COVID. You're doing, temporary tents, or you have a van you're going around, or you're going to other places and providing the services. If you're adding temporary sites, you just need to be sending an email to your project officer and notifying them of those sites to make sure you get the coverage. Also, even though they're saying it's not technically required, we recommend that on Form 5C, you add any of the off-site type of services you're performing so that it's clear that what you're doing is within your scope. There are many states that have implemented separately immunities for people working on things relating to COVID, but today's webinar is solely focused on FTCA and not going to address those specific state ones. If you have questions about your specific state, please reach out to us and we'll answer those questions. But today is about FTCA coverage, right? So as I've mentioned in the past, the reason why these applications have become so much more complex is that, like everything else in the healthcare world or in the world in general, there's been a tremendous growth, unfortunately, in the number of cases that are being brought. And so HRSA has a problem because they have a budget set aside for paying for these cases and they're exceeding their budget. And also because the U.S. Attorney's Office, right, are the people who have to defend these cases are people who work in the U.S. Attorney's Office who, went to all these great schools and consider themselves to be the best and the brightest and don't want to be defending medical malpractice, right? That's like the worst thing they could possibly do. And so they are pushing back on HRSA, and the budgetary factors are causing HRSA to be more careful about who is being approved and what activities you need to take, right? Before, I'm going to say 3 or 4 years ago, there was no such thing as risk management, right? We had quality assurance, and we had claims management, and we had a little bit about credentialing, and now risk management has sort of taken over, and become the primary focus of the FTCA application. And risk management involves activities you're performing. It involves approval by your board. It involves a lot of reporting, setting goals, things like that we'll go through today. And so it's become much more detailed. I will just mention the tip we always mention, which is the line between quality assurance and risk management is very blurry. And so our recommendation is that anything you do for one, you include the other, right? So if you have a quality assurance committee, the committee should be called quality assurance and risk management. Any meetings you have should have both titles in it, and you should be putting both of these things, all these things under both titles so that you can cover everything you need to be doing. As I mentioned, okay, so just a couple of other high-level things before we get into the details. So one of the good things this year is that they have put in many yes/no questions instead of actually having to submit policies and procedures or describing it, just asking you, do you have it in place? Now that's great. That's much better for the application. However, obviously, we're not going to advise anybody to check yes on the application if you don't have it in place. And you need to make sure if you are going to have a site visit, they're going to check to see that you actually have these policies in place. Now, one of the things that people have often asked is what would lead us to having a site visit? And the answer to that is there are a number of factors that HRSA has said would be a basis for it. One is if you had a number of cases. A second is you're just unlucky, you got picked out of a hat. A third could be that you had an unusual case. So it's very hard to be able to predict. If you are having a site visit, it is, I'm not going to, mince words here. It is really rough because, right, on your regular OSV, when they come in for the 2.5 days, right, there's 1 out of the 3 people who's spending, half their time on risk management type issues. Whereas if you have a FTCA visit, you have 2 people coming in for 3 days focusing solely on risk management and quality type issues. So it's much more intense, and they're looking at very detailed level. They're looking for safety issues. They're going to walk around and check all your medications, make sure they're not expired, and your Purell dispensers to make sure there's actually Purell in them, and a lot of different things like that. And so I would recommend that if you are the subject of an FTCA review, that you reach out to us, because there are many more things you need to do beyond what we're discussing today specifically. Okay, so the application is broken down into 4 separate sections, right? Risk management, QA, credentialing, claims management. Like I said, there's a lot of overlap between them. And they are now requiring that you have to tell them if you have any active conditions relating to it, that relating to your FQHC would have to be disclosed as part of the application. So now to get into the details, I'm going to turn it over to Sandy Jensen to walk through the specifics.
Okay, great. So our slides are pretty detailed, and we do that for several reasons. And the most important is that, we only have an hour here, and we're going to have to go through this quickly, and then we'll send the slides out, and you can use it as a resource. And a lot of the information in here, if you go back to the PAL or the compliance manual, they require, let's say, a test that the health center has a risk management program, but then there's additional details in the slides that aren't in the PAL or the compliance manual. And just so you know, we got that from various sources that HRSA has put out. For example, webinars. They put out a lot of webinars on FTCA and the application and what they're looking for. And of course, it goes well beyond what's in the PAL. So what they're looking for goes beyond what they're setting out in the compliance manual or the PAL. And, as Jeff had mentioned, he was in the unique position of being able to sit at the table when one of our health centers was going through an FTCA site visit. So we got great information on, specifically what they're looking for. And again, way beyond. I mean, you could agree that it's horrifying, Jeff, right? It went way beyond anything that could have been in any compliance manual or PAL or.
Yes, and just to add to what Sandy is saying, right? It's when they come on site, it's not just what's in your FTCA application that they're looking for, and it's not just what's in the compliance manual. There are minutia that they look for that no one expects. Thankfully, this FQHC that had it was prepared for it, but they are really looking at everything from top to bottom. The best I would describe it is in states where you have like Department of Health review, where they're coming in to look at all the clinical aspects and and things like that, and checking the equipment to make sure that it's sterilized and all those kinds of things. They do that during an FTCA review.
And so these slides, if you're questioning where it came from, know that it came from HRSA, and this is what they're expecting and looking for. So with respect to risk management, like previous years, there has to be an individual responsible to oversee the risk management program. They have to complete annual healthcare risk management training, and that has to be done within 12 months of the day that you're uploading your application. And so what they clarified in one of their trainings is that they expect to see a progression of training. So you can't submit documentation that every year the risk manager completed level 1 training from ECRI. It would have to be level 1, then level 2, and so on. You also have to upload the risk manager's position description. They indicated that health centers generally, the best document that they upload is the position descriptions, and that's pretty much the easiest because you just have to make sure that for the risk manager, that it states that their responsibilities include risk management activities. So use those words, like use risk in the duties, and that it has to be part of the risk manager's daily responsibilities. So they want to see a person designated for this role that is involved in it on a daily basis. You have to attest that you have a risk management program. This is a system-wide program that looks at every area to try to identify potential risk. And it has to include patient management activities, including triage, scheduling, missed appointments, intake, tracking, and follow-up. So in 2019, HRSA issued an FTCA specific site visit protocol. And if they were coming on site to review your FTCA documentation, they would require written policies on all of those patient management activities. So how your staff triages patients over the phone, how you handle no-show appointments, urgent care visit triage, and walk-in patient policy. And for no-show appointments, when we ask health centers what they have for this, usually it's a policy from the dental department saying, you know, if you fail to keep your appointment, you'll get charged so much and we'll discharge you after 3 missed appointments or something similar. But that's not really what they're looking for. They want to see that you make some sort of determination on whether you should follow up with the patient to determine why the patient didn't show up for an appointment. So you don't have to follow up on all patients, but you have to make some sort of determination, maybe those with chronic care management issues where, you know, there could have been a concern of why the patient didn't show up. So your risk management program has to include risk management training, completion of quarterly assessments, and annual reporting to the board. So the annual risk management report to the board, this one is the one that always causes me a lot of concern because every year HRSA seems to add to what they want to see in this report, and it's always really detailed. So it has to include risk management activities, the status of this health center's performance relative to goals, and proposed activities for the next 12 months. So this year, they really clarified what the report must include. It has to include analysis and trending of data. And one thing about that that I think health centers miss is they want to see that you're reporting to the board on trends. So for example, let's say incidents. If you have needle stick, so first quarter you have 1, maybe second quarter you have 2, then you're taking some action in the second quarter. Maybe you established a goal of better training of staff to avoid needle stick injuries. So then you're analyzing how your goal, which is lowering incidents and implementing the mitigation efforts of training staff, how that translated to your third quarter and fourth quarter data for incidents. Did they go down? Did they go up? So they want to see this analysis and trending of data. So you could do that, for example, patient satisfaction. If patients are upset about wait times, you can do trends related to wait times and establish a goal of reducing wait times. But then don't forget the analysis. In your report, you have to analyze the trends and see if your mitigation strategies impacted the trends in each quarter. So they want recommendations and next steps for the upcoming calendar year. So that's just goals, your goals for the next year. So they want claims information as well, and that's just a summary of your claims. But please remember that if you have an open claim, you shouldn't put a lot of information in there about, for example, yes, the patient was injured and it was all of our fault. You should really just put a summary for open claims of what the claim was and when it occurred and what the status is.
Right, but just on that point, besides where you're putting the application, this is actually an issue that comes up a lot, right? Depending on what state you're in, your internal QA records may or may not be protected under some kind of privilege. And so you need to be careful, right? They want you to document, misses and near misses, but you need to be careful in how you're documenting that, because you don't want to have some piece of paper someplace that says, we completely messed this up and we were 100% liable and we did it absolutely wrong, right? You want something that recognizes there was an issue and talks about things we're doing, prospectively, to make sure we don't have this kind of issue again, but not something that says straight out we are guilty. That, right? Because if it's not protected by a
Right.
privilege and it's part of a litigation, the plaintiffs, the person suing you can get that. And when HRSA finds out that the plaintiff got that thing, they're not going to be very happy with you. So you need to balance doing QA and also protecting yourself.
Right. Great point. So there's, as you can see, there's other bullets too. And just to not take up all of our time on this, if you have any questions, you would give us a call, but it has to be pretty detailed. So as in other years, you have to upload your tracking policies, and they have specific requirements which are required for each that we'll go into. So for the hospital tracking, you have to track certain information. That's the patient information, date of admission or visit, notification, reason if you know, what documentation you received and when. You have to document follow-up initiated with the hospital. So they want to see, if they come in for a site visit, they want to see that on such and such a date, the hospital was contacted or a patient was contacted to obtain the relevant discharge documents. You also have to have staff members that are responsible for doing all of this. So it can't be just whoever's free. It's a good idea if they check to see if any hospital information was received. There should be somebody designated whose job it is to track these hospital admissions and receipt of documentation. So just a point, if some of you are confused about the PAL, in prior years, you had to track hospital admissions where the patient went on their own and when the patient was referred from the health center. So the compliance manual that was issued changed this and just required tracking of hospital admissions if the patient was sent to the ED by the FQHC. However, if you look at the PAL, it says upload your hospital tracking policies that include procedures on hospital admissions ordered by the providers or initiated by the patient. And so we reached out to them and pointed out that the compliance manual didn't require this anymore. And they agreed with us and said, yes, it's just hospital admissions ordered by health center providers. However, it's in the application again this year. So that is not the correct requirement. You're not required to track all hospital admissions for those that the patient went on their own. The second tracking policy you have to upload is your referral tracking policy. And, there's certain elements that have to be in this one as well. You have to define the referral type, whether the patient initiated it or whether a provider wants to send the patient to a specialist. You should also discuss, and this came from the site visit protocol that we attended. You should also discuss whether it's an urgent referral or a routine, and that just changes the speed of a health center's action. So if it's an urgent referral, you might say that your center staff will assist the patient in making the appointment. If it's routine, you might have the patient make the appointment on their own. So your policy should talk about how it was initiated and timely provider follow-up. So, the big concern is you make a referral for something life-threatening and the patient doesn't complete the referral or you don't receive the results and nobody follows up on it. So they want to see a process in place where somebody is tracking and following up the referral. And these are just the information that they require in the tracking policy. Also patient compliance is in there as well. And just one thing about that, So you'd have to determine whether the patient made the appointment and followed up with the referral, and if not. And if the patient didn't comply with the referral, you would just want to stress to the patient how important it is to comply with it or keep the appointment. So diagnostic lab test tracking policy. This is really important, and they actually added a training requirement related to adverse test results. So for both diagnostic testing and lab testing, so radiology and lab, your policy must include both. We had an application rejected where the health center sent a radiology testing policy and a lab testing policy. And they didn't approve the application and said resubmit one policy that includes both radiology and lab. And so those are the elements that they laid out that they want to see in the policy. So this year, this isn't necessarily new from what they've said last year, but they're stressing it. They stress that for normal results, and Jeff and I are never popular when we say this, you have to report to the patient any normal results. And we always hear back, so a strep test, we could do 1,000 strep tests a day. We have to call the patient or communicate the results back to the patient. That's the expectation of HRSA. And this year, in their webinar about the FTCA application, now they've included a slide just on reporting normal results back to the patient. And so here, the elements are laid out. Again, it's not really something different than what they've said in the past, but they're making it crystal clear that they expect normal results to be reported back to the patient. And you have to document patient contact efforts, including date, time, method, who you contacted, whether you were successful or unsuccessful, and any other clinical information as appropriate.
Right, but so within that, there are different ways that you can do that, right? So it could be a phone call to the person, it could be a letter, it could be that the person is scheduled to come back a few days later and you give them the results then. That's okay, but you can't say that the person will come back in 6 months from now and I'll give them the results when they come back at their next visit. That's not okay. Generally, if it's more than a week, you're probably not okay with just relying on the next visit. And like Sandy said, just saying if I don't call you in the next 2 days, assume it's okay is not okay.
Okay, so for abnormal results, it's very similar to normal results. Again, communication to the provider. The time frame for communication to the patient usually for abnormal results are much quicker than communicating to the patient for normal results. So if a normal result is when communicate within 4 days, maybe abnormal is, within a day or two. Again, documentation is key. They also indicated that for them, differentiating between abnormal versus critical results is key. For critical results, they want to see that you've made every effort to contact the patient. So during the FTCA site visit, they specifically wanted to see and have the health center revise their policy with respect to critical results to say that if the patient wasn't contacted by phone that day, then you contact the patient's representative if they gave one. If that contact couldn't be made, you make a home visit or you contact the local authorities to have the authorities try to make a home visit that day. So they're very focused on communicating with the patient ASAP for critical results. And for critical results, they also want to see that your policies include tracking and monitoring and also audit reports to QI/QA. So you have to attest that you've implemented your risk management operating procedures. So your program is the overall system that you have in place to mitigate risk, and your operating procedures are your day-to-day activities that you'll undertake to implement your program. And that includes identifying the areas of highest risk and mitigating those areas of high risk. So how do you identify them? Some services that you provide are high risk just by virtue of the type of service. So dental and the opportunity to or the exposure to infectious disease make that a high risk area, or OBGYN is a high risk area. And you mitigate those areas of high risk by establishing protocols or supervision. So you would have infection control protocols, or you would have your ACOG protocols. But they want to see what you have in place to mitigate the risk. You have to document, analyze, and address clinically related complaints and near misses. This year they added sentinel events, and those are where something unexpected happens that causes a really bad result, like a serious injury or death. You have to set and track your annual risk management goals. Again, your risk management training plan and your annual risk management report. So training, where your job descriptions were maybe your best area of compliance with FTCA, your risk management training plan, HRSA found that this was the weakest application submissions across health centers. So your annual training plan must incorporate all of the trainings that are listed in the PAL, including this year they added medical record documentation. So if you look at the FTCA site visit protocol, and when Jeff was sitting in on the OSV, they spent a considerable amount of time looking at how the health center documents patient visits and their medical records and how you archive it. And so medical record documentation has been added, and also following up on adverse test results. And again, that goes back to their focus on the critical values of your diagnostic test tracking policy.
Okay, also, I'm sorry, on the risk management training, just for a second. So this is one of the areas where people have a lot of problems, especially because there are new requirements this year. So I will just throw out, a number of you have reached out to us, and we have a risk management training that we perform, which can be done, through the same kind of GoToWebinar or Zoom or something like that, where in about 45 minutes we train all of your staff on all the requirements that are, all of the FTCA risk management requirements, and we do like case studies and things like that, and it's been very successful. So to the extent that you need help with risk management training, please, reach out to us.
So obstetrical procedures, this is not new. Just a reminder, though, that even if you don't do delivery, if you provide prenatal and postpartum care, you do have to provide obstetrical training as part of your risk management training plan. You have to, your training plan that you upload has to include training on infection control. For those of you that offer dental services, it has to include dental equipment sterilization. Hand hygiene is really big during the FTCA site visit. They want to see that your infection control includes hand hygiene, HIPAA, and other applicable medical record confidentiality requirements. So the language in red is new. And this is any requirements that your state would have. So in New York, we have mental health special requirements for some mental health providers, or substance use disorder disorder records. There's special confidentiality requirements for those as well. And finally, specific trainings for a group of providers that perform services that could lead to risk. So you might have a risk management training specifically for your internal medicine providers, and you would talk about risks that are that happen in that department. So that could include like documentation issues or cutting and pasting in medical records, or something that's tailored to that group. So again, just to reiterate, the training plans have to include all of the trainings outlined in the PAL. Whatever they put in the PAL, use those words and put it in your risk management training plan. I like to show them exactly what they're looking for so there's no confusion. You'll have to upload, so you have to upload the training plans, and you have to upload tracking documentation that shows that staff completed the training. So in the prior years, you would upload your tracking documentation in your tools. So that would be like your blank sign-in sheets or your blank Excel sheets. This year, they said they don't want any blank documents. They just want your completed spreadsheets or training reports or sign-in, sign-out sheets that show that your staff have actually completed all the training that you set out in your training plan. So the requirements for risk management training, it has to be tracked. The training has to be part of performance reviews and credentialing and privileging. So, you know, I know a health center that has a little box on the credentialing application for re-credentialing. It's like has all required trainings, including risk management trainings, been completed? Or on performance reviews, did the provider complete all required trainings, including risk management trainings? You have to have a process for handling those staff who fail to complete the required training. So you could send them, an email, give them a due date, maybe have the department director reach out to them, and then send it to HR to implement tougher sanctions. So you also have to upload assessments, and it's up to you what you want to talk about in these assessments, but it could be any risk management activities that have taken place during that quarter. These are quarterly assessments, any data or trends. So again, when I was talking about the trending for incidents, so quarter one you had like 2 needle stick injuries, and quarter 2 you had like 3, and so these could be in your risk management committee minutes. And as Jeff mentioned, we recommend combining the committees, so it could be QA and risk management committee. You could talk about your patient grievances. You could do data and trends about grievances. But again, it has to be quarterly, so you have to submit at least 4 documents to show that you've done something on a quarterly basis. And this year, they note that it has to be reflective of the last 12 months. So your governing board...
Just on that, the 12 months goes by when you submit the application. So you got to look back and see, right? So normally people like to wait till the very last minute to submit the application. But if you have things you did last year in June, that means you want to get, we did it on June 25th the last year, and you want to get your application in before June 25th this year if you want to be able to include those activities.
Right. So the governing board requirements, the most important of that is that you have to show proof that the board received the annual report. So in their minutes, you could upload their minutes, but make sure the minutes say annual risk management report to the board. Basically make it clear to them that they have received, or the board has received, the annual risk management report to the board. And then any discussion, it would be great if there was discussion and that was included in the minutes, because they want they want to see that the board actually is taking a role in risk management. So moving on to QI/QA, there wasn't a lot of changes made here, but when I review applications, I always have concerns about the assessments, and most health centers submit their minutes, and sometimes I'm concerned because the minutes don't accurately reflect everything that the FTCA is looking for. So you have to have, you're no longer required to upload your QI/QA plan. According to the FTCA PAL, last year I think you still had to submit it, even though the PAL didn't require it. but you have to attest that in your plan, you have operating procedures that address adherence to current evidence-based guidelines and a process to identify, analyze, and address patient safety. So the first bullet, what they're talking about really is, peer review, and the second, that you have an incident policy where you are collecting like grievances, incidents, near misses, and now sentinel events, and you're following up on that. So I think I just mentioned your operating procedures have to address assessing patient satisfaction. So that's a big deal to them as well. And you could do it however you choose. You can try to assess patient satisfaction on your own by having designated staff, call, or maybe you hand out a postcard or have a patient, one of those patient boxes in the wait areas, or some health centers contract out for that. And then they get reports back from the contracted entity on the results. You have to have a patient grievance policy, and this should be like a formalized policy. A lot of grievances can be handled informally, but you should have a process in place where the patient can make a formal grievance. Again, completion of these periodic QI/QA assessments on at least a quarterly basis, and producing and sharing reports on QI and sharing it with the governing board. So the QI/QA assessments, they can either be reports or committee meeting minutes, or you can have a document called QI/QA assessments, but you have to upload at least 4 of them because you have to prove that you did it on a quarterly basis. And these assessments have to include, again, peer review and identification of patient safety and adverse events. And so, sometimes I'll see peer review maybe addressed in January and then addressed, in September again. You have to be able to upload that on a quarterly basis something was done in peer review. So you don't have to always do peer review in one department every quarter. So you don't have to conduct peer review of the internal medicine department every 3 months or every 4 months, but you have to do something on a quarterly basis. So it could be internal medicine, the first quarter, and dental the second quarter, and behavioral health the third quarter. And then it has to go back to the QI committee. It should be discussed. And for the FTCA site visit, they want to see that all of that went up to the board, and the board is made aware of peer review as well. So these assessments, so peer review is really your peers are looking at, the peers of a provider are looking at their records or patient records to make sure that those met clinical guidelines, standards of care, and standards of practice. So the compliance manual clarified that these have to be done by physicians or other licensed healthcare professionals under supervision of physicians. And again, it has to look at patient records to ensure compliance with standards. You also have to upload the most recent report to the board, and that could be like maybe a comprehensive discussion in the minutes that was then presented to the board. And your board minutes have to document that the report was shared and discussed. So again, to make it easy, your board minutes can say QI/QA report shared with the board. So it's easy for them to see that you've met this requirement. So the person in charge of the QI/QA program doesn't have to be a clinical person. However, the QI/QA assessments, because they're peer review, that has to be done by clinical staff. Also, the person in charge of the program can be an employee or contractor, full-time, part-time. It's up to the health center to determine. And we get this question a lot, whether the QI/QA person can also be the risk manager, the compliance officer. That's fine, but make sure the job descriptions outline all of the responsibilities. And here we go with the job description. those 3 bullets, ensuring implementation of and updating QI operating procedures, and the other 2, make sure that language is in the job description. That was specifically their requirements in the PAL. And the job description has to clearly state that the QA activities are part of the individual's daily responsibilities. You have to indicate yes or no whether you have implemented an EHR, and you have to attest that you have systems and procedures in place for protecting confidentiality. Now, if you had an FTCA site visit, you'd have to prove that your system matches that, and you'd have to show all of your confidentiality policies. And governing board requirements, again, it's receiving the report, having support, having really oversight on QA, and the compliance manual requires that the QA policy be reviewed by the board at least every 3 years. So you don't necessarily have to make changes to it, but the board has to review it at least every 3 years. So our next area is credentialing and privileging, and this is another area that didn't change too much from last year. The most important pieces of this is that you have to make sure that you include all required personnel. And what we see a lot is that OCSs, the other clinical staff, are not included in the policy. And I know that HRSA has said if you don't use other clinical staff, then you don't have to include them in your policy. But what I would recommend is a line in the policy itself saying, our health center does not include other clinical staff, and therefore they are not included in this policy. So other clinical staff are just unlicensed staff that do not fall into LIPs or OLCPs. And so, for example, New York doesn't require certification of medical assistants or dental assistants, so they would fall in other clinical staff. But some states do require certification of medical assistants, and so they would fall under an OLCP. So it's really state specific, but if your health center doesn't use other clinical staff, I agree that HRSA has said you don't have to include them, but I still would include a line saying you specifically did not include them because you don't use them. So the credentialing elements that HRSA looks for are listed. One note about basic life support. So not all of your staff needs basic life support certification, but you should identify which ones you are requiring. So you might require basic life support certification by all medical assistants and RNs, but not LPNs. So you would want to just identify which category of staff you require life support training. Okay, now moving on to privileging. So there's two different requirements for credentialing and privileging are really two different things. Credentialing is making sure that they have all the required documentation and experience and training. Privileging is making sure that they're fit to do the job. So under that is fitness for duty, immunization, and communicable disease status. And again, for the FTCA specific on OSV, they wanted to see that you list out right in your policy what immunizations and communicable disease status you're going to be looking for. But for the FTCA application, they didn't go that far. So for initial privileging, you can verify current clinical competence through their resumes, so through training, education, and if they have available references. With respect to references, they want to see that you're getting a reference from someone at the same level or above as the provider, not a subordinate. Now, for renewal of privileges, so this is someone that's been working with you for 2 years, you would verify current clinical competence through peer review, or you could do a supervisory performance evaluation. And your policy has to include a process of denying or removing privileges based on clinical competence or fitness for duty. You have to keep files or records for clinical staff of your credentialing and re-credentialing and re-privileging records. And during an OSV, you're going to have to pull this all out. So you also have to test that if you contract with provider organizations or have written referral arrangements, your contracts have to include those 2 bullets listed on the slide. So your contract would say, contractor ensures that providers are licensed, certified, or registered through a credentialing process, and they are competent and fit through a privileging process. And during the FTCA site visit, they look at every single contract to make sure those 2 bullets are there. Some important clarifications that the compliance manual made. You're not required to employ your clinical staff. You can have contracts to carry out all the services, except you have to directly employ your CEO or project director. So FQHCs have the flexibility to determine who has approval authority for credentialing and privileging. So you also have to, I was going to say the board can decide that, the medical director makes all approval decisions, but that's really for HRSA purposes. You also have to keep in mind your state law requirements. So your state might require that the board approve physicians or, all of your LIPs. So for HRSA, the board can decide to have the medical director approve them all. However, during the FTCA site visit, they said, well, even if the board decides that the medical director can approve credentialing and privileging, you should still go back and inform the board who was given privileges at the health center by the medical director. So they still want the board to be knowledgeable of who's providing services or privileging decisions that were made. Again, we talked about this before, but this is a good option for FQHCs. You can verify current clinical competence through peer review, or you can just do a supervisory performance review. And you have the flexibility to determine how credentialing will be implemented. So you can contract with a credentials verification organization, or you can have dedicated staff, your HR department, do all the follow-up for the credentialing activities. For claims management, you have to attest that you have a claims management process that includes preservation of all health center documents relating to any actual or potential claim or complaint. So that's a litigation hold on your documents, basically. So if you got an incident and let's say an incident happened where okay, I'm thinking of dental, a wrong tooth was extracted, and that could potentially lead to a claim, then you would have to issue a litigation hold to make sure all of the documents were maintained. Or if you receive a complaint, you identify all the appropriate departments and parties that could have information, and you issue a litigation hold. And the second part of your process has to include promptly sending to the Office of General Counsel any service of process or complaint received so that they could take immediate steps to defend against that complaint. You have to upload your claims management procedures, which includes both of those elements. And this year they said that, your process has to be clear and detailed and align with the elements in the compliance manual. And the compliance manual elements are those two noted above. So you have to indicate, this is not new, you have to indicate whether you had any claims during the past 5 years. And that goes right into the application. So this year they clarified that for each closed claim, and this goes back to what Jeff was talking about regarding making sure you don't put anything in writing about open claims that are still being defended. So for each closed claim, they're looking that you include a description of what mitigating actions you took to prevent or mitigate the occurrence of a similar future claim. And that includes the bullets below. So you could have developed a new policy or procedure as a result of it, or credentialing and privileging actions. If it was a malpractice action, you could have limited the privileges, or you could retrain. You have to upload the claims manager position description, and this year you have to include a screenshot of the exact location where this information is posted, informing the public of that you're a deemed health center employee. So you would take a screenshot of the entire page, not just of the language, so that they could go on your website and see where on that page the information is. So we're up to the point of the volunteer health professional coverage, and we only have 3 minutes left. Basically, this is not new. It's just a means by which you could get your volunteers covered under the FTCA. You have to sponsor each volunteer, so you can't submit one sponsorship application for all of your health center's volunteers. You have to name them in the application, and if your application is approved, only that named volunteer will have coverage. And there's certain requirements that include, the service that the volunteer is providing must be in your scope of practice. You have to sponsor them. They cannot receive any compensation, although you can bill for the services. There's certain notice requirements for patients, and the volunteer has to be licensed. You have to maintain all of your documentation, and you still have to credential and privilege the volunteer.
Okay, thank you. Okay, thank you everyone for joining us. If you have any questions, please submit them to us. Like I mentioned before, we have FTCA training materials available, and make sure you have a grant policy relating to using the COVID funds for emergencies. Thank you for joining us this afternoon. Have a good day.